coming up in this episode so that when you're walking to your stroke call or when you're in your stroke call and you're trying to find the cookie jar and the feather, you don't have to try and Google it and then you don't have any internet reception in the regional hospital's emergency department, or you're scrolling through 2,000 baby photos and you can't find the photo. That is so infuriating. Hello, and welcome to the next installment of Risfeld Neurology Education, a not-for-profit, free open access project with a philosophical touch, exploring all areas of clinical neurology, meant for medical students through to neurologists and all health professionals caring for patients with neurological conditions. I'm your host, Tom Risfeld, a neurologist, epileptologist, and neurophysiologist and neuromuscular specialist, and also a physician, philosopher, and bioethicist. I'm really excited to announce that this is the first episode in the Stroke and Cerebrovascular Diseases series, and it therefore has a different color background. I've gone with a red background, which is the color of the awareness ribbon for stroke and cerebrovascular diseases, and it's also falling within the series of clinical method. And the episode is titled NIHSS or NIHSS, Hyperacute Stroke Examination with Pearls and Pitfalls, and we'll be focusing on the theory behind the examination in this episode. Before we begin, a legal disclaimer. The content of this episode is for educational purposes only. So let's dive into it. The way that I think about it when I'm attending a hyperacute stroke call is that there are 3 or 5 main pieces of information that I really need to quickly and accurately elicit. The reason I say 3 or 5 is there are 5 things, but the first 3 things are the 3 things you really, really, really need to get down on top of. And then the other 2 things are going to be very important in terms of your decision making regarding candidacy for hyperacute stroke management or not. But the first 3 are really, really, really important. So the first thing is, when was the time last seen well? Or if it's a wake-up stroke, what time did they go to bed? What time did they wake up? And therefore, what was the midpoint of sleep, which can then be taken as the time last seen well? Secondly, what is the patient's baseline function? And that's defined by the MRS, the Modified Rankin Scale. And thirdly, what is the NIHSS score, the NIHSS score? And that's the National Institutes of Health Stroke Score. And this is going to be the focus of this episode because it's how you examine a patient at a stroke call. The other 2 components, so the fourth thing is what other comorbidities does the patient have, in particular previous ischemic or hemorrhagic strokes, atrial fibrillation, any cerebrovascular stenoses, so carotid artery stenosis, any known intracranial atherosclerotic disease, ICAD with MCA stenosis, for instance, middle cerebral artery stenosis, any posterior circulation stenoses, so any vertebral artery stenosis or basilar stenosis, and also knowing what the patient's other vascular and metabolic risk factor profile is, so obesity, hypertension, dyslipidemia, and diabetes mellitus in particular, and also smoking status. Also, does the patient have a history of a condition that could be associated with stroke mimics, in particular epilepsy or functional neurological disorder, FND, or some other conditions as well, which could manifest as a stroke mimic? And also, is there anything in the past medical history which would be a contraindication to thrombolysis? And that also, I'll bunch it in here, the current blood pressure is also important. And then the 5th really important thing is what medications is the patient on, but specifically what anticoagulants and or antiplatelets is the patient on. So I'm going to do a separate episode explaining how to run a stroke call and how to put all of this together. But this specific episode is going to focus on the NIHSS assessment itself. So how to do the NIHSS assessment. So let's dive into it. So how is the NIHSS actually written? So if you look up their website, you can get the exact wording, and we'll be going through it in this episode. And the way it's scored is it's a score from 0 to 42. And one confusing thing is if you chose the highest score on each item and you added it up, it's actually a score of greater than 42, but it's actually not possible to get a score of greater than 42 because if the patient was, say, brain dead or completely obtunded, GCS3, completely unrousable, you would score a score of 42, but it would not be possible to score on some of the other items, such as ataxia, for example. So that's why the maximum score is 42. And the lower, the better. So 0 is really good, and 42 is absolutely horrific. And the way that the scale has been designed is it's been designed, obviously, to be fast, and it's designed to elicit the key clinical signs necessary in order to make an accurate diagnostic stroke assessment. But importantly, it's also been designed for consistency and for low inter-observer variability. That's obviously important in clinical trials, but it is also really important in clinical practice because often there's going to be multiple people involved in a stroke call, and you're comparing or making treatment decisions based on evidence from clinical trials. So if you're examining a patient and you score them a particular NIHSS and then you're making a treatment decision based on the published literature, you want to know that your patient actually has the same NIHSS score as the patients that were enrolled in the trials, and that their clinical state is not actually different because you haven't done your NIHSS accurately. Also, it's pretty common that a more junior doctor will be the doctor who's actually doing the stroke call. So maybe that will be the person on the floor. So maybe that's the neurology advanced trainee. Maybe it's the basic physician trainee. If it's in the middle of the night, based on the staffing of the hospital, it may be the emergency staff, or if you're in a regional area, it may be the emergency staff. And then the person who's actually making the decision in regards to, are we going to thrombolize this patient or not? And are we going to refer this patient to the neurointerventional team for mechanical thrombectomy or not, is someone who's often not actually present on the floor by the bedside. It's often the neurologist, the stroke neurologist, who's over the phone. So it's really important that the person actually doing the examination is able to generate a NIHSS score which is consistent, accurate, reliable, so that the decision-making made by the other person is then based on accurate information. So in order to get accurate information, obviously you need to know how to administer the scale correctly. Technically, you're only supposed to test each component of the score once, and you score the patient's first attempt. So what that means is you're not supposed to go back and retest items and then change scores. And that's quite an important thing to recognize. And also it's slow. If you're going back and changing scores and retesting things, then that's just slowing you down. The other thing is, technically, the NIHSS publication states that you're not supposed to coach and encourage the patient. In my own experience, realistically, I don't think that's particularly realistic. And I see patients being coached and encouraged a lot. And I can see why it's included in the publication, but I don't think it's completely unreasonable to coach the patient if they're clearly apathetic and disinterested, and they don't really want to be there, and they don't really want to be engaging with you or doing the NIHSS assessment, but they might not actually have true neurological deficits. So I think in that circumstance in particular, it actually is important to try and get the best response out of the patient that you can, because you don't want to harm a patient by scoring them with a misleadingly high NIHSS score and then treating them inappropriately either. So maybe the patient actually is a stroke mimic, or they're actually a minor stroke, but they're just not that into it and they don't really care and they're not giving it their best effort. You don't want to score them a really high NIHSS score when actually they don't have anything near the neurologic deficits that you're indicating in your NIHSS score, and then maybe thrombolizing that patient inappropriately. So you don't want that. So what I propose we do in this episode is, firstly, I'd like to go over the NIHSS items in the order that they're published, and we'll go over the wording, and at the same time I'll talk about how they are tested and how they are scored. And then in the second part of the episode, I'd like to suggest some little tips and tricks that I've picked up on over the last 10 years or so. And the reason for doing this is I think it helps with memorization of the NIHSS protocol, and it helps with memorization of general neuroanatomical principles overall, and with stroke management principles overall. And I think it helps with increasing the accuracy of your NIHSS assessments and also the efficiency of your NIHSS assessments. So let's dive into it. Firstly, how are the NIHSS items actually published and what order are they published in? So the first one is item 1A, which is just called level of consciousness, without any additional qualifier. And it's scored from 0 to 3. 0 is the patient is alert and responsive. 1 is the patient arouses with minor stimulation. 2 is the patient requires repeated or significant stimulation to rouse. And 3 is that they are not rousable at all. So despite really quite repeated and vigorous stimulation, including noxious stimuli, the patient cannot be roused at all. That excludes any motor reflexes, though, because we know that a patient can be obtunded and still have motor reflexes intact, so that's not counted. And you shouldn't really be examining motor reflexes in a hyperacute stroke call anyway, because that's not part of the assessment, and that's wasting time and wasting dying neurons. The second item, item 1B, is level of consciousness, but specifically orientation. So to test this, you ask the patient the month and their age in years. And they score 0 if they answer both questions correctly. They score 1 point if they get one of the questions correct and the other one incorrect. And they score 2 points if neither answer is answered correctly. Item 1C is level of consciousness, but specifically it's about following commands. So what you do here is you ask the patient to close and open their eyes, and you ask them to make and release a fist. And of course, that should be using the non-weak side of the body if the patient is hemiparetic or hemiplegic. And again, this is scored between 0 and 2. So 0 is the patient correctly follows both commands. 1 is they correctly follow one of the commands. And 2 points is if they don't follow either of the commands. So pretty simple, straightforward thus far. The next item is item number 2, which is the patient's best horizontal gaze. So this is first examined without the oculocephalic head maneuver, and then if necessary, it's examined with the oculocephalic head maneuver. And it's just like the way that we examine extraocular movements when we're doing our cranial nerve examination, except that we're just focusing on horizontal gaze. We don't care about vertical, we don't care about up and to the left, down and to the right. We're just doing left and right, and we're looking at both eyes. So this is scored between 0 and 2 again. You score a score of 0 if there is normal horizontal eye movements bilaterally in both eyes. And that's not a tautology because it's meaning that the left eye can move left and right and the right eye can move left and right. So it can cross the midline bilaterally and get to the end of the normal range of vision in both directions in both eyes. Conversely, you score 1 point if there is abnormal gaze, but it is overcomable with the oculocephalic head maneuver. So what is that? So basically, if you're doing your just follow my finger left and right, and you notice that the patient has some form of gaze palsy, so if they can cross the midline to the left, but they then can't cross the midline to get to the right, you then do this oculocephalic head maneuver. So you put both of your hands on the patient's head like this, and then you quickly move it to one side, and you look at what the eyes do, and then you repeat the process to the other side. And what you're doing is you're assessing for the horizontal vestibular ocular reflex test. And we actually talk about this in an upcoming episode of Untitled Neurology Education, where we talk about the HINTS examination, when we talk a bit more about the vestibular system and neurootology, and we talk about the head impulse test, which is very similar. So the way to think about this is if you have a doll, literally a doll, like a child's toy with some eyes which are just buttons that are sewed onto the fabric of the head of the doll. If you got that doll and you move the head to the side, obviously the buttons would just move with the rest of the face. So the eyes would continue looking in the direction that the head is then moved into. So that would be abnormal vestibular ocular reflex testing, in that their eyes do not stay fixated in the original position. They just move with whatever direction you move the head in. So that would be if you did that in a patient or a person with a hyperacute stroke, for instance, which is affecting horizontal gaze centers, then what you may find is you get the patient to look at you, you ask them to continue focusing on your nose if they're able to comprehend that, and then you move their head quickly to one side and you look at what their eyes do. And if the patient's eyes are able to remain fixated on your nose, so what that means is the eyes point then in a different direction to the head, so they're actually pointing at your nose and they're actually deviating to the side, then they don't have a forced gaze palsy. It's overcomable because actually with this head reflex testing, their eyes are able to move to the side. So that would be scored a 1 in the NIHSS. Conversely, if you do the head reflex testing and they have a doll's eyes response, so despite your head reflex, the eyes don't stay fixated on your nose, they just move with the head and they just stay looking in the direction that the head is turned into, then they score a 2. So that's a fixed gaze palsy or a forced eye deviation. So hopefully that wasn't too confusing. I might quickly repeat that, but using a left and right just to make the example a bit clearer. So suppose you get the patient to look to the left and they can't move their eyes to the left. So they get to the midline and they can't move to the left. What you would then do is you do your head reflex test and you would quickly move the patient's head passively to their right side, and then you're looking at what their eyes do. And if their eyes just stay in the same direction as their head, so when their head moves, their eyes just move towards the right and they don't stay looking at your nose, then that's abnormal and that's a forced eye deviation or a fixed gaze palsy, and they would score 2 points. Conversely, if their eyes are able to stay focused on your nose so that when their head moves to the right, their eyes actually cross the midline and are actually moving to the left side relative to the direction that their head is in, even if there's a bit of a delay and then they are able to move to the left, then that's not a forced eye deviation or a fixed gaze palsy, that's overcomable. So they would score 1 point, not 2 points. The other thing to say here is what we've been talking about so far has been binocular gaze palsies, but sometimes a patient might have a monocular gaze palsy, and so that would then be a problem with conjugate gaze. So both eyes are not looking in the same direction. One eye might be looking one way and the other eye is looking the other way. So that might, for instance, be seen in the context of a unilateral third, fourth, or sixth nerve lesion, or in the context of horizontal eye movements, in particularly a third or a sixth nerve lesion. And that could be in the context of a stroke as well, because we know that the nucleus for those cranial nerves lies in the brainstem. So in the third and the fourth nerve, that's in the midbrain, and for the sixth nerve, that's in the pons. So if you have a brainstem stroke, that can knock out, so a posterior circulation stroke affecting the brainstem, that can knock out the cranial nerve nucleus, and so it could cause a monocular gaze palsy from a stroke. So these are actually scored as a 1, not as a 2. So if someone has a monocular gaze palsy, but they are able to cross the midline horizontally bilaterally in their other eye, that's scored as a 1, not scored as a 2. Now, let's move on to the next item number 3, which is visual fields testing. So this is tested by a confrontation, very similar to the way that we would normally do it in our normal cranial nerves examination, as described in one of my previous episodes. The additional points to mention in the NIHSS context is that if the patient is unable to focus on your nose and they keep just looking in the direction that you're testing, you don't have to try and retest it 20 times, 30 times, 50 times until the patient consistently looks at your nose and correctly says that they have peripheral vision, because you're going to be wasting way too much time by doing that. And especially if the patient's had an acute stroke and they're confused, it may just be impossible for them to follow that instruction. Conversely, you are allowed to infer that the visual field is actually intact if they are consistently correctly deviating their eyes towards the side of the field that you were testing. So to use an example, if you're testing the right inferior quadrant and you're asking the patient to look directly at your face and you're testing the right inferior quadrant and they're not following your instruction because they keep looking down into the right inferior quadrant to directly look at your hand, which is moving, you are allowed to infer from that that quadrant's visual field is intact because the patient keeps consistently choosing that quadrant correctly. If the patient has impaired visual fields, then the next thing that you do is you proceed to examining visual threat. And it's important to know how to do that. So what you don't want to do is you don't want to use a big gush with your hand and end up blowing a big gust of air in the patient's eye and causing them to blink, because that could be causing a false result where it appears that the patient is responding to visual threat by blinking, but actually it's just because you've pushed a gush of air into their eye. Conversely, you want to come from the side and just do like a little flick or something similar so that you're entering their visual field and causing some form of visual threat, but you're not causing a big gush of air into their eye. The other thing to note is that the visual field testing really focuses on binocular problems in the context of a NIHSS assessment. So the publication specifically states that monocular blindness, including enucleation, so if someone only has one eye, that is not scored for the purposes of the NIHSS. So how is the NIHSS scored? So it's scored from 0 to 3. 0 is a normal score. 1 is a partial hemianopia, which basically just means a quadrantanopia. 2 is a complete hemianopia, which in the stroke context basically always means a homonymous hemianopia. And 3 is complete bilateral blindness. It's actually stated as a bilateral hemianopia, which is a bit confusing the way that it's been worded in the publication, but what it means is a complete bilateral blindness. Conversely, as I just said, if someone was completely blind in one eye, especially if it's because some chronic problem like glaucoma or a retinal detachment or a previous central retinal artery occlusion, and they're just blind in one eye, but they've got completely normal fields in the other eye, then that tells us that the upper motor neuron components of the visual pathway are intact, and that's what we really care about in a hyperacute stroke assessment, and that's what the NIHSS is designed for. So that would actually score a 0. So even though the patient is completely blind in one eye, the fact that they have normal vision in the other eye means that the pathways for the visual modality are intact, so they score a 0. The next item is item number 4, which is facial palsy. So to examine this, you ask the patient to raise their eyebrows, close their eyes nice and tight, and then give you a smile. Maybe you can ask the patient to show you their teeth as well, like this, big smile. And this is also scored from 0 to 3. So 0 is if the patient has symmetrical and normal facial movements bilaterally. 1 is if there is minor paralysis of the lower face. And what that means in practice basically is if the patient just has minor subtle nasolabial fold asymmetry or minor subtle smile asymmetry. And you have to be mindful that some patients may just, as their normal facial appearance, have minor asymmetry to their nasolabial folds or to their smile. You score 2 points if you have partial paralysis, and what that means is partial paralysis to the lower face with forehead sparing. So if it's more than just a bit of minor paralysis, if it's more than just a bit of asymmetry with the nasolabial fold or with the smile, so it's pretty significant weakness in the lower face, but it's sparing the forehead, then that scores a 2, and we're talking about unilateral weakness really. And then you score a 3 if you have complete paralysis of the forehead and the lower face, and that's unilateral usually, or if you have bilateral complete facial paralysis. So if you have a facial diplegia, then that also scores 3 points. And you might wonder, why is the forehead being involved given that stroke is an upper motor neuron pathology? And the reason for that, which I did discuss in the cranial nerves episode, is that strokes, especially big strokes and nasty strokes, can in fact involve the forehead as well, and that's why it's included in the NIHSS. And the reason for this, firstly, is you could have a posterior circulation stroke affecting the brainstem and actually knocking out the nucleus of the 7th nerve, also in the pons, and therefore causing a lower motor neuron pattern of weakness, even though it's a stroke in the central nervous system in the brainstem, but it's knocking out the nucleus to the 7th nerve, which is located inside the brainstem. Or the second reason that you can get it is if you have a large anterior circulation stroke, which is affecting the upper motor neuron, but it's also affecting some of the decussating contralateral fibers involved in the contralateral upper motor neuron representation of the forehead, or if it's affecting the centers in the supplementary motor cortex, so anterior to the precentral gyrus, then that can also cause failure of the contralateral representation to the forehead, so you can get forehead weakness in a big nasty stroke. So that's why that's included in the NIHSS. The fifth item in the NIHSS is motor arm. So what you do is you ask the patient to hold out each arm at 90 degrees if they're standing, or at 45 degrees if they're lying down in bed. So basically you're just completely against gravity. So at 90 degrees if you're sitting, or if you were lying in bed, 45 degrees would still just be against gravity like this. And you have their palms down, so we're not interested in pronator drift, it's just with the palms down. And we're assessing this over 10 seconds for any drift. And this is scored from 0 to 4 for each arm, and then the 2 are added, so the left arm gets a score from 0 to 4, and the right arm also gets a score from 0 to 4. 0 is no drift. 1 is there's some drift, but the arm doesn't reach the bottom of the range of motion within the 10 seconds, so it doesn't hit the bed if there's a bed in the way, or it doesn't totally drop down if there's nothing in the way. 2, so a score of 2, is if there is some effort against gravity, but it does reach the bottom of the range of movement or hits the bed or whatever obstacle is in the way within the 10-second period. 3 is there is no effort against gravity at all, so it just falls down immediately, but there is some degree of anti-gravity movement, so there is some movement there with gravity eliminated. And 4 is there's no movement at all. You can also get an untestable score, but that's only in the context of a patient who has an amputation or a joint fusion. Whereas if the patient is obtunded because they've had a massive stroke and they've got a GCS of 3, that doesn't get scored as untestable. That gets scored as 4 for no movement at all. So you only get an untestable score if the patient just doesn't have an arm, or they've got a fused arm and they literally, for musculoskeletal articular reasons, literally can't move the joint. The next item number 6, is motor leg. And this is essentially exactly the same as for the arm, with the only exceptions being it's tested over 5 seconds as opposed to being tested over 10 seconds. And I think that's because the leg is just a bigger, heavier limb, and so it's harder to keep your leg in the air for a long time compared with keeping your arm in the air for a long time. So that's why the threshold is lesser for the leg than for the arm. So just remember, arm 10 seconds, leg 5 seconds. And it has to be tested with the patient lying supine, and it's tested at 30 degrees. So you don't really need to remember the number 30 degrees. You just remember you have the patient's leg a bit up in the air, just at basically a sensible angle, and you assess for limb drift in exactly the same way that you do as in the arm. The next item number 7, is limb ataxia. And this is done by assessing finger-nose testing and heel-shin testing bilaterally. And what you're doing is you're looking for ataxia which is out of proportion to the weakness, and this is explicitly stated in the NIHSS publication. So if the patient is really weak and then they have some limb ataxia, but that's clearly proportionate to the degree of the weakness, then that's not supposed to be scored according to the NIHSS publication. So you're looking for ataxia which is disproportionate to the weakness. Now, in terms of the scoring, it's scored from 0 to 2. 0 is no ataxia present in any limb. 1 is ataxia present in one limb. 2 is ataxia in 2 or more limbs. And untestable, again, is only really if the patient has an amputation or a joint fusion. But unlike for the power testing, if the patient is confused and can't cooperate with the assessment, or if they're paralyzed or obtunded and you can't examine for limb ataxia, then you score a 0 as opposed to scoring them points for being ataxic. So it's only if you actually demonstrate ataxia that you score them for that. The next item is item number 8, which is sensory. So this is examined in the face, the arm, the trunk, and the legs bilaterally. Not too distally, so you don't really want to examine the fingers and the hand or the toes, because if the patient were to have, say, a diabetic length-dependent sensory polyneuropathy, we don't really care about that. We're looking for evidence of cortical or central nervous system pathology affecting sensation. So you want to test more proximally, so you want to test at the elbow or proximal to that, and at the knee or proximal to that. and it should be tested using a pinprick based on the NIHSS publication. So this is scored between 0 and 2 again. So 0 is no sensory loss at all. 1 is partial sensory loss, so that means an asymmetry or a reduction in the intensity of the pinprick, or the pinprick being felt as a touch but not as a noxious stimulus. And then 2 is if the patient has complete loss of sensation on the affected side of the body. So that means that the patient is not even aware that they're being touched in the area that you're examining. The next item is item number 9, best language. So here you need some equipment, but you can just get it on your phone. And there's this particular scene. The one that I'm familiar with is the cookie jar scenario. And then there are these pictures of various objects, and the page that I'm familiar with has got a hammock and a feather, etc. And then there are some sentences which you ask the patient to read from. And an interesting point here is if a patient is blind, then you can get around this by asking them to name objects that you've placed in their hand. Or if a patient is intubated but they're not sedated, then you can feasibly ask them to write to test their language. Because importantly, in this item, we're testing the patient's language. So their receptive and expressive language, but we're not interested in testing their speech or their vision in this item. So this is scored from 0 to 3. 0 is no evidence of dysphasia. 1 is mild dysphasia, but the patient is still fairly easy to understand. 2 is severe dysphasia, so the patient is very difficult or maybe unable to be understood. And then 3 is complete or global dysphasia or mutism, so the patient's really just completely unable to communicate and unable to comprehend anything at all. The next item, item number 10, is dysarthria. So to do this, as per the NIHSS publication, you get the patient to read the words from the list that they provide. And this is scored from 0 to 2. 0 is a normal score. 1 is mild to moderate dysarthria. So what that means is the patient slurs, but they can still be understood. So you can still make out and figure out what they're saying, and you can still communicate with them. And 2 is severe dysarthria. So this is the patient is so dysarthric that you really just can't understand what they're saying, or they're just completely mute or anarthric, in other words. And this can be scored as untestable if the patient is intubated or there's another physical barrier to them opening their mouth and them talking. But importantly, if the patient's had a massive stroke and they're obtunded, you still score this as a 2, and same with the best language before it, you would still score that as a 3. So you only get an untestable score for dysarthria if there is intubation. Really would be the only physical barrier that I could think of that would truly prevent someone who otherwise could talk from talking. The final item, item number 11, is extinction and inattention, formerly known as neglect. And this is involving multiple modalities, so visual, tactile, auditory, spatial, and personal modalities. And this is scored from 0 to 2. 0 is no inattention in any modality. 1 is inattention in one modality. And 2 is inattention in 2 or more modalities. So that's it. Easy, right? Now, what I'd like to do in the second part of the episode is to give you my general tips and tricks and suggestions, and then tell you how I like to do my NIHSS assessments in the way that I think really is helpful and may also help you remember it. So in regards to the general tips and tricks and suggestions, I would really recommend trying to just memorize the NIHSS assessment so that you can just do it on autopilot mode. So you don't want to be at a hyperacute stroke call and thinking, oh my God, I can't even remember what is in a NIHSS, because that's not where you want to be starting. Obviously, everyone needs to learn, and that's why practice is so important. And if you're more junior, then going along to a stroke call with someone who's more senior and observing how it's done, just really try and memorize the NIHSS so that you can just do it on the fly. You're not trying to think about what the next component is. You're not trying to find a sheet of paper to tell you what to do next. You can just do it in your sleep. And that means you can then focus on interpreting and putting the signs together and making a diagnostic impression and coming up with a management plan. So you're doing that higher order thinking, basically. what I normally do is I do the NIHSS and then I'll pull out my phone and I'll pull out a phone app at the end when I'm done, such as MD Calc is the one I like to use, but there may be others as well, to quickly add up the scores if it's a high score. So if it's only a score of 1 or 2, I don't need to double check that on my phone, but if the score is 15 or 20 or something like that, I'll then put the components into my phone at the end quickly to get the actual score. Of course, if you do forget a component of the NIHSS, you can do the same thing, quickly just pull out your phone, go on MD Calc or similar, and it will tell you exactly what you need to do, so you can just do it quickly. Once you've practiced this over and over again and you're really competent at administering a NIHSS, you should be able to do a NIHSS within a couple of minutes. So this should not be something which is taking a long time. It should be bang, 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 get it done really quickly. Because you've got to remember that it's always a trade-off against the clock. You're losing 20 million neurons every minute is the number which is often quoted, so you want to be quick. You also need to be as accurate as you can be and as reproducible, of course, as you can be. So it is a bit of a trade-off, and I don't think it's too controversial to say that there is a bit of a difference in the significance of a slight difference in a score depending on whether you have a low score or a high score. So honestly, the difference between scoring someone a 31 and a 32 in clinical practice does not have any clinical significance whatsoever. You're not going to change your management on the basis of someone having a NIHSS of 31 as opposed to them having a NIHSS of 32. You're going to be doing exactly the same thing in terms of your investigations and your management. 1 point between a 31 and a 32 is not going to change anything. Why is that important? You need to be accurate, you need to be reproducible, you need to get it right, but you don't want to spend an extra 5 minutes doing the most perfect NIHSS assessment in the world if it's just going to change a 31 into a 32 or vice versa. So you need to make some trade-offs in terms of your accuracy versus how long you're taking to do the NIHSS assessment. Conversely, in the low score range, the difference between a low score and a slightly different low score is much more clinically significant. And in particular, a good example would be the difference between a 5 and a 6 is very clinically significant. Or in lower range scores than that, in some particularly important subcategories, the difference between scoring a 1 and a 2 in a particular subcategory is also really important because some of these subcategories are considered as being really important in terms of distinguishing a disabling from a non-disabling minor stroke. And both of these have a very significant implication on whether or not a patient is appropriate for thrombolysis and or thrombectomy on the basis of whether they have a minor stroke or a moderate stroke, or whether they have a minor disabling stroke or a minor non-disabling stroke. And there's been quite a body of literature published on this recently, and it's basically shown that dual antiplatelet therapy is non-inferior to thrombolysis for minor non-disabling strokes. And that's actually been a practice-changing body of evidence which has come out during my career. So when I was a BPT, a basic physician trainee, and in the earlier stages of my advanced training, when I was going to hyperacute stroke calls, that body of literature wasn't there. And we were treating patients more aggressively, and we were thrombolizing patients with NIHSS of 2 or 3 sometimes. But now with this new body of literature, if a patient has a non-disabling minor stroke and a NIHSS of 3 or 4, then often, or even 5, then often we would not thrombolize that patient on the basis of this body of literature. And in terms of mechanical thrombectomy, the same threshold is generally the case. Of course, it's going to be a case-by-case basis, and it's going to be at the discretion of the neurointerventionalist, whether that be a neurologist or a neurosurgeon or an interventional neuroradiologist. But most of the mechanical thrombectomy or the ECR literature is based on the patient having a NIHSS of 6 or higher. So basically, you want to be really, really, really accurate, especially if the patient has got a NIHSS in the ballpark of, somewhere between 0 and 6 or 0 and 7. But you don't need to sweat it if you're not sure if a patient has a NIHSS of 31 or a NIHSS of 32. Don't waste time in that context. Now, the other side of that is, yes, I've been emphasizing how important it is to be quick and efficient. You don't want to lose all your 20 million neurons per minute. But the other consideration is you don't want to be so rushed that you're just a nervous wreck and that you're forgetting items and you're doing an inaccurate examination, because that's not helping anyone, because that just leads to misdiagnosis and it leads to inappropriate treatment decisions. So it is okay to take a deep breath, and it is okay to slow down a tiny bit, a tiny bit. You don't want to be in a state of brain fog yourself, and it's just about trying to get that balance as to where you're being as fast as you can be while still eliciting an accurate score. And that just comes with practice and experience. So, how do I like to do my NIHSS assessments? Perhaps somewhat controversially, even though the NIHSS publication explicitly states not to do the NIHSS out of order, I think it's faster and easier to remember and more logical if it's done slightly out of order in a top to tail approach. It doesn't majorly change the order. There's just one or two items that move around a little bit, and I just find it makes the whole process more fluid, smoother, it flows nicely, it's easy to remember, you don't skip things, it just works. So this is the way that I like to do it. You don't have to do it this way, but you might consider it. So I group it into 4 main groups. So rather than having to remember 11 groups, there are 4 main groups of things that you're doing. The first group is your cognitive higher centers components and the visual components. The second group is the other face components, which is the motor, sensory, and inattention testing in the face. The third section is the arm components, which is the motor, dysmetria, sensory, and inattention components in the arms. And the fourth components are the leg components, which is again motor, dysmetria, sensory, and inattention testing in the legs. So it's more of an anatomical approach. So we're doing the cognitive and higher centers and visual at the beginning. And that's important because it really informs the rest of the assessment. If someone's blind, or if someone's obtunded, or if someone is confused or dysphasic, you do have to take that into consideration in the way in which you examine and speak to the patient with all the other components of the testing. So those important aspects are still done at the start. And then you're just doing all the motor, sensory, and inattention stuff after that, and you're doing the face, and then the arms, and then the legs, including coordination in the arms and legs. So, do I have any tips and tricks on accurate and quick examination of specific items? So, let's go through it. This will hopefully not be too repetitive. I'm just going to focus on any little additional suggestions I might have. So, regarding the cognitive and higher centers assessment and the visual components, you're doing your level of consciousness, no changes there. You're doing your orientation, no changes there. In regards to the commands, and also in regards to the neglect testing, both of these are actually already assessed later on in the assessment. So I don't really think you need to do it at this point, because by the end of the assessment, just by doing all the other components of the NIHSS, you will have already assessed the commands and neglect. So I just skip it at that early point. So I remember there are the 2 consciousness and orientation based things. Then I remember there are the 2 vision based things. And it's important, as I just mentioned, to do vision early on in the assessment. So firstly, there's the vision and fields. Even though it's not a component of the NIHSS, I think it can be helpful to just really quickly ask the patient to count your fingers in each eye, just to quickly determine whether the patient does actually have monocular blindness or not, because it totally affects the rest of the visual assessment, and it totally affects the rest of the assessment as well. And it's just an easy way to quickly elicit whether the patient has severe blindness or not in one or both eyes. And it only takes, 2 or 3 seconds. You're not losing a lot in terms of time by doing that. Then in terms of the field testing, this is going to contradict the golden rule from the cranial nerves episodes, but in the hyperacute stroke setting, it's the one exception where it is acceptable, and in fact it's recommended, to test the eyes together, so with both eyes open. The reason for this is, in the hyperacute stroke context, we really only care about a homonymous field defect, particularly if the patient obviously has a major stroke syndrome. So if you get a call from the emergency staff, or you get a pre-notification call from the paramedics, big stroke call, patient's hemiparetic and dysphasic, we're not looking for a branch retinal artery occlusion causing a monocular quadrantinopia. Let's be realistic here. We just want to know, when we're doing our visual field assessment, does the patient have a big nasty homonymous hemianopia or not? So by testing the eyes together with your field testing, you are saving a considerable amount of time. It's a different story if you're looking for a central retinal artery occlusion or a branch retinal artery occlusion in a different context. And yes, they are or can be considered as essentially strokes of the eye, and sometimes they are stroke calls. That's different. So if you're called to see a stroke call in the emergency department and it's for monocular, sudden, painless visual loss, which is in a quadrant or in the complete eye, and you're thinking about a BRAO or a CRAO, that is still a medical emergency that needs to be acted on quickly, and you will often be called to stroke calls for that. And in that instance, absolutely, you need to test the eyes individually. But in your classic context of a big nasty stroke call, patient with a high NIHSS, you want to get onto things quickly, it is okay to test the eyes both open at the same time. I then test for neglect at the same stage, and I noted that the NIHSS publication also recommends doing the same thing. And I already said this, so I won't have to say it again, but just to reiterate the tips that I gave in terms of visual threat testing, so you're not pushing a big gush of air into the patient's eye, just do a little flicker instead. I must say, in my experience over the last decade or so, I don't think that the visual threat testing is that helpful most of the time. It's pretty rare that someone has a quadrantinopia or a hemianopia, and then you do visual field testing, and then they actually do respond to visual threat. And so you're able to demonstrate that actually their field was intact when you thought it wasn't. That hardly ever happens. So I don't think it's super helpful. So don't waste too much time on the visual field testing. If someone obviously has a quadrantinopia or a hemianopia, quickly do a flick in the quadrants, try and determine whether they respond to visual threat or not, but only spend 5 or 10 seconds on that. Don't waste a lot of time on that. Next is the extraocular horizontal movements. No changes that I have to state here. The only thing which I think was also mentioned in the publication from memory is that it can be really helpful to actually just reposition yourself. So if you're standing on the right side of the patient's bed, and then you're trying to test their gaze to the left and they're just not looking to the left because they're focusing on you, it can be really helpful if you just walk around to the left side of the bed and try and get their attention and see if they will actually divert their gaze and look at you. Because it may be, for instance, that the patient has neglect and they may be neglecting the left side of their visual fields, and they may be neglecting the left side of the space around them and the left side of their body even. But it's not actually a problem with their horizontal extraocular movements themselves. So if you can trick the patient in a way by walking around into the other side of the bed, making a noise, really trying to get their attention, then suddenly they might actually cross the midline and actually turn their eyes to the left. So that's a good tip. Then we've got our 2 language and speech domains, which I bundle up here. And again, I like to do this early on because it informs the rest of the assessment. So regarding the dysphasia testing, what I would really strongly recommend is find the cookie jar scenario on the internet on your phone and take a screenshot of it, and find the page with the feather and the hammock and all the other objects and take a screenshot of it and save both of the photos in a favorites folder in your phone, maybe its own favorites folder, so that when you're walking to your stroke call or when you're in your stroke call and you're trying to find the cookie jar and the feather, you don't have to try and Google it, and then you don't have any internet reception in the regional hospital's emergency department, or you're scrolling through 2,000 baby photos and you can't find the photo. That is so infuriating. Or sometimes it's helpful if there's a stroke nurse in attendance at the stroke call and they sometimes actually just have a physical copy of them. But if there's no stroke nurse, I don't walk around with a physical copy of them. So if you just have it saved offline in the favorites folder of your phone, you just pull it up really quickly, done. Some people skip or cut corners here and they make an assessment of dysphasia without actually testing the cookie jar scenario and the feather, which is probably a bit naughty. I don't think it actually takes that long to actually test it properly as you're supposed to by asking them to describe the cookie jar and the feather and the hammock. Obviously, if the patient is GCS3 and they're obtunded, you're not going to waste time by trying to get someone who is barely breathing to tell you if they can describe a cookie jar scenario correctly or not. So you have to exercise a bit of common sense here. The other thing is that you should have already made a bit of an assessment of whether the patient is dysphasic or not during your very, very brief history and during the NIHSS that's already performed up until this point as well. In terms of dysarthria testing, again, you should already have partly assessed this based on the brief conversation that you've already had with the patient up until this point. And you can ask the patient to read out aloud the specific words and sentences, which is published by the NIHSS body, and you can save them on your phone as well, and that is also used to assess dysphasia. I usually don't do that. I don't really think that's completely necessary. I normally just ask the patient to say British Constitution, Westminster Register, Hungry Hippopotamus, ask them to say some difficult, or not ridiculous, but somewhat difficult words to pronounce to try and ascertain whether the patient is dysarthric or not. And they're the phrases that we usually ask the patient to say when we're assessing dysarthria and other contents or not. But you're really just trying to establish, is the patient not dysarthric? Do they have a subtle dysarthria, or do they have a severe dysarthria? So I wouldn't sweat this one too much. I wouldn't waste too much time on this one. Just make an assessment and move on. We can now move on to the sensory and motor components with the rest of the body. And so you group this into the face, the arms, and the legs. Easy. So face, you do your motor, and then you do your sensory testing, including tactile neglect. Arms, you do your motor. And I would argue that when you're testing arm motor, if you ask the patient to raise their arm and they listen to you and they do it, you've already assessed that they're responding to a one-step command. So are you really achieving anything in addition by asking them to make a fist as well? I would argue probably not. But to do it by the book, at that point, you could also just ask the patient to quickly make a fist. So you've tested that component of the NIHSS as well. Similarly, with the testing facial power, you're asking the patient to close their eyes anyway. So you're already testing the motor response to closing their eyes at that point. Back to the arms, you're then doing dysmetria, and you're then doing your sensory testing, including testing for tactile neglect. And then in the legs, again, you're doing your motor assessment, you're doing your heel-shin incoordination testing, and you're doing your sensory testing, including tactile neglect. So what other tips would I have here? Regarding motor testing, the one thing I'll say is I really would recommend against verbally counting down aloud from 10 in the upper limbs or from 5 in the lower limbs. And the reason I wouldn't do this is because the patient hears you counting, and what happens all the time, in my experience, is when you get close to the end, but you're not quite at the end yet, so maybe when you get to 2, the patient then loses their enthusiasm and they start to drift just before you get to 0. That is really frustrating, and it happens all the time. So what I would recommend instead is you need to count, obviously, because you need to know how long you test for, but just count silently in your own head so that the patient doesn't have this anticipation of when the count is going to end, so they don't then give up and have a little bit of limb drift just before you finish counting. The other thing is, it does say not to coach the patient. I don't think it's unfair, however, or unreasonable to ask the patient to keep the limb up and say, keep it up during your testing, so that the patient is motivated to continue keeping their limb up in the air whilst you're testing it, and so that they know that they need to continue to hold the limb in the position until you tell them that that's enough and they can stop now. And actually, I do think that this saves time because, of course, you're not meant to retest it. And so if you just do it right the first time, that's all you need to do. And then you've got a more accurate and a more efficient item scored, which is good. Regarding dysmetria, no changes, just exactly what I said earlier. And then regarding sensory testing, in reality, in Australia at least, almost no one actually uses a pinprick when they're assessing sensation in a NIHSS. I must have attended hundreds, probably into the thousands of stroke calls, and I cannot say that I have ever seen anybody else ever use a pinprick when they're assessing a NIHSS. Everyone just uses light touch. Technically, that's not the right thing to do. It does say that you're meant to use a pinprick. When I was earlier on in my career, I was using a pinprick. Although I think I can see the other side of the coin, and it's probably not completely unreasonable to compromise a bit. Ideally, if you happen to have a pinprick in your pocket and you've got one on you, then you should use it. That's a good thing to do. But you should not waste time looking for a pinprick if you don't already have one, or waste time looking for a blunt drawing up needle if you don't already have one. And I don't think it makes a really big or a significant difference because, let's be honest, we're not trying to delineate someone who's got spinothalamic tract involvement from someone who's got dorsal column involvement. We're not trying to perform an assessment on someone with a sneaky myelopathy versus a small fiber or a large fiber peripheral neuropathy. We just want to know, does this person have a stroke which is causing cortical or subcortical but cerebral or brainstem interruption of the sensory pathways? So if you test light touch and they have impaired sensation versus they don't have impaired sensation, I think you've answered your question and you've done your job. And of course, you can just test for neglect quickly at the same time by testing light touch with your fingers. So by the end of this assessment, you've already achieved the other items. So you've already assessed the ability of the patient to follow motor commands, including the face and limb movements, as I said earlier. And you've also assessed essentially all of the neglect modalities. So you've already tested visual neglect, you've already tested tactile neglect, and you've already made an assessment of any obvious spatial or personal neglect. So spatial neglect is the patient is just completely being inattentive to one side of their environment, and that should be obvious by the positioning that you have in the room and the way that they're responding to their environment. And also you've made an assessment of personal neglect. So that's neglect to one side of their own body. So if when you were testing their arms and their legs, they seem to just completely neglect half their body, you've already made an assessment of personal neglect. The only exception is aural, AURAL neglect. I wouldn't recommend actually testing specifically for aural neglect by testing for bilateral hearing. I've never seen anyone do that. I think that's a bit over the top. If someone doesn't have visual, tactile, spatial, or personal neglect, I think you've done your job there, and then you can score for your neglect item as well. So that's it. I really hope that I've been able to clarify any misunderstandings in regards to some of the items in the NIHSS and explain the rationale behind the NIHSS items. I hope I've been able to emphasize why it's important to perform the NIHSS quickly, really quickly, but how it's always a balance and a trade-off against your accuracy and your reproducibility. And it's about finding that balance and doing it as best you can while still maintaining accuracy. And it's all about practice, practice, practice. And I hope that I've been able to communicate with you some tips and tricks that you may agree with and that you may find useful, and it may help you remember the NIHSS, it may help you perform it quickly and accurately. So that's it for today. Please like, comment, and subscribe if you found this episode helpful. Visit rneurologyeducation.org, that's R with the letter R, for all of our media formats and additional content. Find our videos on YouTube and our audio podcasts wherever you listen to your podcasts, and join us on your preferred social media platforms, all at the domain rneurologyeducation. And email us at contact@rneurologyeducation.org with any questions that you may have or to subscribe for updates. From cortex to curiosity, this has been Risfeld Neurology Education. Until next time, keep calm and synapse on.